suspecting acromegaly, if you're having all of the signs like frontal bossing, my ring changed by a couple sizes, my boot size changed, hyperhidrosis of the palms, etc. If you're having some of the signs and symptoms and you want to check to see if the patient has acromegaly, the first test to do is a random IGF-1 level. Boom. Easy test. Easy test. So, like I said, I'll harass this a lot. Growth hormone levels initially are not useful. Why are they not useful?
They fluctuate?
Exactly. Pulsate 8 to 12 times a day. Like you can just exercise a little bit and this is going to pop up. So the electrons fluctuate of pulses. So if it's normal, it's not acromegaly. Boom. Don't do any further testing. Wrong diagnosis is okay. We got that. Wrong diagnosis is not acromegaly. Okay. If it is abnormal, the IGF level is elevated, then you follow up with one fasting IGF-1 level. So that's a one test. And then you give them 100 grams of glucose. Why would I give you glucose? What's that? Normally your growth hormone should drop. Exactly. So measure your serum growth hormone, such as fasting at one level, and then give them 100 grams of glucose. Sound like a fun Snickers bar or whatever. 60 minutes later, measure the growth hormones. At that time, I can confirm it, because by default, hyperglycemia should make growth hormone go away or be more non-existent. If the growth hormone is elevated, acromegaly is confirmed. Okay, so yeah, a lot of stupid testing we have to do, whatever, it's endocrine, it's not my fault. But so first start with a random IGF-1 level. Boom, if that's elevated, I think this person might have this. So next step I do is a fasting IGF-1 level. Give them a Snickers bar, not really, it's not a Snickers bar, but just 100 grams of glucose. And then I check the growth hormone level, because default, the growth hormone should plummet after I give you hyperglycemia. Remember, like, look at the things that stimulate it, things that cause it to be inhibited. Growth hormone gets inhibited if I have hyperglycemia. So that gives a hyperglycemia in this case. So it should plummet. In this case, if it's elevated, boom, you have acromegaly. Does that make sense? Did I confuse anybody? I promise I didn't make this shit up. All right. So you do not need to memorize the level over 1. Not at all. Don't memorize this. Level over 1. Just so you know, if it's elevated, that's a problem, right? Because it should not be elevated in this case. So the other things you're going to check as well. You can check it up here, random IGF-1 level as well up here, or down here if it's fasting. Either one. What you want to check some other things. So one, a prolactin level. That is very, very common to happen in the same person who has an acromegaly. They also have prolactin secreting tumor as well. And then in glucose, which is included with the CMP. The TSH, because I'm weird like that. And then the TSH, because again, sometimes you have multiple things influencing it. Because again, it's often a macroadenoma. It's pretty large. Makes sense? So the reason why I'm checking, I don't care if we do it when it's the random one or the fasting one of these times you got to check these other labs because multiple hormone issues as well. Make sense? Cool. All right. So always labs first and then imaging. Do not, I repeat, do not do imaging in a patient before you confirm that with labs. So always do the imaging after the labs, after you confirm it. There's just saying MRIs are really expensive. Makes sense? So don't do it. So MRI of the brain pituitary, state of choice. And like we talked about macroadenoma, very possible. So I put this in there because it's in a lot of your, it's within current, the textbook I referenced. So basically, what if I have my growth hormone levels elevated or my IGF-1 levels elevated or they're both elevated, but it's not from this condition? That's when I'm talking about differential diagnosis. What else could it be if it's not acromegaly? It's oftentimes you like a little bit elevation, stuff like that. So again, just something to think about with different features that could be a different diagnosis. It's a busy slide, don't hate me, sorry. The first thing you do if you're thinking somebody has acromegaly or gigantism, either one, is surgery. Treatment of choice is surgery, right? What's the treatment of choice for a prolactinoma? Medical, exactly, medical stuff. Now we're talking about surgery. That's the treatment of choice for these guys. Symptom remission in 70%. So not all of them. Or what if my carotid arteries are too close? Because it was wacky. So then you probably do something else with it. In his case, he had the radiation therapy. So medical is not sufficient alone if you have persistent acromegaly despite the surgery. Like I said, this is my friend Brian. So these are some things that were in a teeny little words, but kind of makes sense, a lot of these things. If you have an elevated growth hormone and IGF-1, but you also have an elevated prolactin level, you can't just treat only the growth hormone. You're going to medically treat it either with cabergoline or bromocriptine, right? So that's one as well. If it's not elevated, you don't have to treat it. Meaning if you don't have an elevated prolactin level. Octreotide and lanreotide, these are your somatostatin analogs, so it's basically kind of suppressing what your growth hormone is doing. So it's effective but expensive. Raloxifene, these are particular for, like males, obviously, postmenopausal or breast cancer. God forbid, sometimes people don't come with one condition, they come with a multitude of things. This can be effective for them. Then picbizumab, this is crazy expensive, $187 per dose. That's a lot of money, but again, it's something can be effective. What I really want to focus on is if I have elevated growth hormone and IGF-1, and I also have elevated prolactin levels, understand we're going to medically treat them with on top of the surgery. That makes sense or confuse the crap out of you. So understand these two, cabergoline, octreotide, these two are really important to add on to, yes.
And with the prolactinoma, you're saying that like 20% of them can cause acromegaly. So if it's a prolactinoma that's causing it, if we just start with medicine and seeing if that fixes the growth hormone piece?
A wonderful question. No, so basically you're saying if I have elevated GH and growth hormone and then elevated prolactin levels, if you have both being elevated, you can't go to medical only therapy. Great question. Does it make sense? So we don't go to medical only. If like surgery wins in this particular case. Whereas normally, in most cases, let's say if I had only prolactinoma or prolactinoma plus elevated TSH, meaning hypothyroidism, medical treatment all day long. But if I have elevated growth hormone or an IGF-1, because they both go together, surgery wins in this particular case. Does it make sense? Did it confuse the crap out of you? Cool. All right. Okay. So stereotactic radiosurgery. If you failed surgery and medical therapy, so this is what my friend went through because they couldn't. He failed. He was on medical therapy as well. He had the surgery first, medical therapy, and still he had a tumor. So he ended up doing the radiosurgery. So basically radiation. And this is a couple different versions of it. CyberKnife, GABA knife. So many other versions of radiation stuff. Don't memorize those at all, but if you just kind of know what they are, it depends on where your facility is located, what they have available to you. But one of the biggest thing is, we talk about this a lot, hypopituitarism risk is greatly elevated in this particular case. We talked about overall what's rated at, but for this particular case, acromegaly and gigantism, it's greatly elevated. So again, radiation at the last moments. Hoping you don't have to do it. All right, so surgery's first, then medical, and then if you need to do it, radiation, but that's a big risk factors. Make sense? All right, so follow up. We love a Christmas. do annual IGF-1 and growth hormone measurements, at least annual. And then if there's any indications of maybe some other dysfunction, we'll talk about how you do cortisol testing and stuff like that. We'll talk about that more in lesson 5. So the prognosis, the soft tissue swelling improves for the most part, but the bony enlargement is permanent. It can't make the bones get smaller. The other thing to keep in mind, we kind of talked about this yesterday, hypertension persists despite everything you're doing. So they often have to be on an antihypertensive medication for life. You can always try, they're very like minimally elevated. You guys take a trial off the medication, but 9 times out of 10, it's going to pop up again and be a problem. Does that make sense? Cool. All right. All right. What do you guys know about ACTH secreting adenomas? Very specific type. Do you happen to know what they're called? What's that? It sounded like I heard it. Maybe I just want to hear it. Yes, exactly. Cushing disease. Yay, good job. Cushing disease. Cushing disease. Now, I point up here all the time. When I'm talking about if I have Cushing disease, it's up here. Cushing syndrome is a big umbrella. We also talk about it a lot. So, understand corticosteroid adenomas, also known as ACTH secreting adenomas. Understand both terms, pretty please. So know both of them. And then also known as Cushing disease, specifically disease. Okay? I said a lot. Sorry. All right. So it is the third most common, right behind acromegaly and gigantism. The third most common, and these are more though happen in women. We're weird, so why not? Most common, a microadenoma. Microadenoma. It is often less than 5 millimeters. That's definitely a microadenoma, right? Remember, anything greater than a centimeter is a macroadenoma. It's a microadenoma, but does not take much. Secreting too much ACTH, right? More than it should be. And by default, what's going to happen? I'm secreting way too much ACTH. What's the downward effect of that? Too much cortisol, exactly. It doesn't take a lot of cortisol to have a great effect. So, this tumor secretes ACTH, obviously, because it's a pituitary tumor. Putting my brain so you guys get left out. Secretes cortisol release from the adrenal glands. So the cortisol excess equals Cushing disease specifically. You have to figure out what the problem is, or to give you some different labs you can do to figure out where this is. It syndrome or is it disease? So believe it or not, this accounts for 68%, not test on stats, but 68% is disease rather than the usual result syndrome. But the key is, we'll talk about this a lot, they both look the same. They both look the same, so don't forget that. So Cushing syndrome looks exactly like Cushing disease. It's up to you to detect where it's coming from. Make sense? All we're talking about this one is disease, but then we get to lesson 5 and talk a crap ton about Cushing syndrome. Because sometimes it's coming from, let's say, the adrenal glands. Sometimes it's coming from a lung cancer. So we'll talk about some other reasons to have it. All I'm talking about this one, because this is the anterior pituitary we're talking about, all we're talking about right now is the disease. Make sense? All right, so CRH, nobody cares about CRH because it's released there, but I care about the anterior pituitary, and that really causes the adrenal glands to release cortisol, and it goes buck wild, okay? So it's not responding to negative feedback. So we'll talk about exactly what lab testing you do if you're suspecting this person has either syndrome or disease. So like I said, I did this wacky drawing. I didn't draw these pictures. I just copied them off the internet. But I made this wacky drawing. So again, Cushing syndrome is the big umbrella. The big umbrella. Whether it's disease or disease or syndrome, either one is included in the overall Cushing syndrome. But keep in mind, most of these cases are actually the disease process. And then the rest of them are Cushing syndrome, which we'll talk a lot about in lesson 5. A lot about. But they look the same. So you're going to see this flash of the slide in lesson 5, exact same one, because I'm lazy. I didn't repeat it. These are your signs and symptoms. Signs and symptoms. And I promise you, nobody's going to have just one of them, like the first one, like fatigue. No, they're going to have multiple of these. And the longer it's been going on, the more side effects they're going to have as far as the signs and the symptoms, okay? I realize a big list. You're like, why are you doing this to me? That's mean. But again, a lot of these make sense, hopefully, make sense. Because what am I doing if I'm retaining too much cortisol? What are my malfunctions? So one of the big things you're going to see is they get a gigantic beer belly with crazy stretch marks. Purple stretch marks. Not like, oh, you got a little chubby. No, these like almost overnight. You're just like, they got really big. So central obesity, fatigue, obviously I told you every fatigue is in every single endo problem I have. So you can cross that off if you want to. So central obesity, plethoric moon face. What the hell does that mean? Plethoric moon face. What's that? Yeah, fat face. What's that? Fat face. But what's plethora? What's that? What's that? Yeah, lots of, exactly. So it means a red face. It's a red face. Yeah. So it's like ruddy colored or red looking face. So they look like they're flushed all the time. Buffalo hump. What's that mean? Exactly. Boom, right here. Exactly. Buffalo hump. Bless his heart. I was working in Eglin Family Medicine Residency Center. So again, they taught. That's my first job coming into the Air Force. It's awesome. We saw like 18, 20 patients a day, which is so much better than my civilian job. It's like 30 patients a day. Dermatology is 40 patients a day, by the way. But anyway, so 18 is like, I can do this all day long. But the reception is there. Every time we walk past her, I was like, I don't know what's wrong with you, but you look, she was like every single one of these. Every single one of them. I mean, some I don't know, but she's amenorrheic, but she had like everything about that. And I wanted to do studies on mother, but I work in a faculty of like 12 faculty members and 10 students each year, so all these medical professionals. Somebody would have thought about this first, but I still want to. Okay, she had everything. I didn't want you to see supraclavicular fat pads. So basically, I'm going to do it one side. Or basically, where this just looks like chubby looking. It's more than that. So typically, everybody can isolate their clavicles, and it's empty up here. It's kind of blank up here. But again, what's that? You should. Anyway, so the other things you're going to have is really cool too. Proximal muscle weakness. Proximal muscle weakness. So basically, weakness of like my bicep and my tricep, weakness of my quads, my hamstrings, a weakness of that. Some people, they may not complain about the issue. They say like, hey, how's it feel when you're walking stairs? Like, oh man, these legs are so sore. Not like walking up IPAP stairs, that's a lot of stairs. But that is a big one. Proximal muscle weakness. Some reason it doesn't affect them quite so much distally. So the forearm, tip fib, that's not as affected, but proximal muscle weakness, which is where the bigger muscles are, that's affected. Purple striae, I should throw it up there, right? Central obesity goes with purple striae. They almost always have stretch marks. Almost always have them. And then not just in the belly, but they're often, they're often on the upper extremities. Sometimes they go on the back or the flanks as well. Sometimes they're on your thighs. It depends on how quickly they gain the weight. So again, weight gain is a big thing. It happens like overnight. So easy bruising and delayed healing, right? They can have both things, right? So I nick myself, shave my legs, and it still won't heal. I don't know why. and I'm just bruising all over the place. I don't know how I did that. Because one of the things that cortisol does to you is it basically, in a good way, it delays inflammation. So again, that's one of the things that happens. I'll go over amenorrhea. It could be either one. Remember, oligomenorrhea means greater than 40 days between periods. Amenorrhea means you stop doing it. Erectile dysfunction, we talk about this a little bit with acromegaly as well, and prolactinomas. Fungal and bacterial infection, more so because they're often more obese. So if I'm more obese, I'm getting tissue hanging down where it shouldn't be hanging down. So that's why you get pannus, which is basically where you have extra tissue, stuff like that. Either one. You could also have people bacterial infections, fungal infections, like a lot of bacterial vaginosis, a lot of yeast infections in women. Those are all common things to happen in some of these patients. Osteoporosis and acne, depression and anxiety, maybe both features, right? I mean, like down and out, I feel like keyed up, one or the other. Hypertension makes sense. And hyperglycemia or just outright diabetes mellitus type 2 is associated with obesity. We'll talk about it a lot next block of material, but I'll talk about it a lot because once it has cortisol affects the body's ability to, it's called glucocorticoids for a reason. So that's the reason why. So you have to make it too much of it. Hyperglycemia is a known effect. All right. Any questions on some of the signs and symptoms? I don't want to read it to you. I just read it to you. So sorry, but I just want to make sure these make sense. Again, a patient's not going to present with one symptom like fatigue and like figure out what's wrong with them. They're almost always going to have the proximal muscle weakness, the beer looking belly. They often have skinnier arms and legs compared to their beer belly, right? So skinny arms and legs, beer belly, buffalo hump, good stuff. All right. That's it in a picture if you like that better. All right, so again, it's not just on the belly, but what do you notice about the stretch marks? You're asking them, exactly. So, but what color are they? Exactly, dark. They either like deep red or like a purplish red. Either one. So normally people with stretch marks, generally they're a lot smaller, and they're like kind of a white silvery color. Most people are. So what's this bad boy? Exactly, it's a buffalo hump. His face doesn't match it, and it should be bigger. All right. So the guy with Cushing's disease, right? Before and after treatment. Yay! We'll talk about how it's treated. So again, if you saw this guy in picture A, would you know that that guy had Cushing's disease or Cushing's syndrome or whatever the case is? Not necessarily, right? We're like a chubby society, so don't do it. But again, if you have him take his shirt off, which I highly recommend doing, not like it just losing the lungs and heart their damn shirt. If you have him take his shirt off, just those stretch marks are key. That is so important for understanding somebody you think has disease or syndrome. Either one, figure out how you figure it out. So again, so this is him after. Yay, good job. So note the stretch marks are still there. Despite all the technology in the world, we can't get rid of stretch marks. It's super lame. But child lives up really big, so you can't get rid of them, but you can make them a lot less prominent, and then probably like a year, 2 years from now, they'll be more faded away, look more like a skin tone, not bright pink or bright red. He's smiling now. He's happy. Good job. All right. Again, would you recognize this person had Cushing's disease, or do you think she's just bad? Oh, shut up. She's not. I know. So this is Danielle. Danielle had a pituitary adenoma. This is her after. Yes, Have some faith, my gosh. She had a pituitary adenoma removed in 2015. Sadly, she had 3 other surgeries involving removing both of her adrenal glands. This is, yeah, exactly. Sometimes your body likes to produce ACTH way too much. So in 2019, she had both her adrenal glands removed. After surgery, she was pregnant. So after she lost a chunk of her pituitary, both of her adrenal glands, she was pregnant. God bless. It was a rough course through her pregnancy. So not only did it gain a significant amount of weight, it developed severe heart issues, kidney issue, gestational diabetes, and kidney stones, a blood clot on my arm, and had surgery 6 months into my pregnancy to remove the clot in her arm. But that is her after. But again, you gotta listen to your patients. If they're saying they gain weight, listen to them. Don't be an asshole. Listen to them and see if they're safe. Now, a lot of people don't have secondary issues, but it's their baby, happily ever after. Good job. So, yes. Yeah.
Because obviously you said acromegaly is like over years.
Yes.
So is this like shorter, longer?
Good question. He's basically at what's the time frame for Cushing disease or Cushing syndrome versus acromegaly, which take a long time. It's kind of a slower process. Yeah, Cushing disease and Cushing syndrome tend to be a little quicker, a lot quicker. So again, but the thing is, the weight gain might not be like, oh, I gained 50 pounds in a year. Anytime someone says 50 pounds in a year, please raise a red flag in your mind. But again, it's not as slow as acromegaly, but it kind of depends on the patient. Some people have a large Cushing disease, Cushing disease syndrome, and so if the bigger it is, the more likely you are to gain the weight and for it to be more harmful to you and have all of those features. Make sense? That gets depends on your patient. But it's not going to be slow. No matter what, it's going to be slow. Not like the 10 years for acromegaly or 8 to 10 years for acromegaly. It's going to be a little bit quicker than that. But you got to have somebody listen to the patient. It's key. All right, so if I give you, I'm going to steal it. If I give you a steroid, an oral steroid, what's going to happen to your natural body steroid? Your natural body steroid. It's going to decrease, exactly. You guys asked me because know that shit already. I'm so happy for you. Because steroids are not until your 4th test, which is weird. In farm. So if I'm giving you a steroid, in this particular case you use dexamethasone because I know exactly the dose, that's the reason why, but any steroid, I don't care what it is, if my body detects I'm taking steroids, by default what's going to happen? My ACTH is like, oh, you're good, going to go down, and your natural cortisol level is all going to go down. Because your body doesn't know the difference between synthetic, a pill, versus the natural cortisol in your body system. Make sense? Okay, so that's key to remember. Cool. So a normal patient. I have wrote this out a couple of semesters ago. I think it's useful, maybe not. Feedback on this, great. If you took a steroid, dexamethasone, that's one we use, the anterior pituitary by default then makes less ACTH, right? Negative feedback, working, doing good. And then by default, the adrenal glands will also make less cortisol. Because it doesn't matter, it comes in a pill or naturally, cortisol is cortisol, okay? And again, this is steroid. So a normal human being would have what level in their cortisol levels? I measure the cortisol. What levels do you gonna have? Would it be more cortisol or less cortisol? Less. Awesome sauce. Yeah, you have less cortisol. So this is what's going to happen in normal human being. So now we're going to talk about this again. We call it Cushing disease and Cushing syndrome. Both are the same test. Good job. Same test. So if you have disease or syndrome, when you take the steroid, if you had disease or the syndrome, the anterior pituitary should make a less ACTH. Good job. Do what it's supposed to do. The adrenal should make less cortisol. Not working. But a person with disease or syndrome, and we'll talk about how to tease it out more so in lesson 5. What do you think is going to happen when you measure their cortisol level the next morning? Boom, it's elevated. That's a problem, right? If I'm taking a steroid, it should be suppressed, right? It should be non-existent, suppressed, because you're taking that. In this case, if it's disease or syndrome, you get more cortisol. Make sense? Hopefully, crickets. Good job. So, we're ready. I put this in white because I think it's better. But so this is what's happening. If I give dexamethasone to a patient and you're normal, pituitary makes less ACTH. Good job. And then adrenal glands make less cortisol. Boom. And you measure the stuff over here as normal. So if I have Cushing disease, this is the only one we're focusing on right now. Only one we're focusing on. Because my negative feedback system is broken, because I had an adenoma in my brain, the adrenal gland makes more ACTH. So by default, the adrenal glands are just idiots. They don't know what they're doing. They just do what they're told. They make more cortisol. The reason why it's coming from up here. Coming from here. Make sense? Okay, so the only one we're focused on right now is disease, which means it's coming from the anterior pituitary, making more ACTH. That's a lot of slides words. So the one I want you to remember is if I suspect this person has Cushing's disease or Cushing syndrome, the first test you need to do is a dexamethasone suppression test. Really, words are hard for me. Dexamethasone suppression test. So what I do is I give you this pill, one single pill. You take it at 11 o'clock at night. And then you go in the morning to the lab, first thing, right off the bat, at 8 o'clock the next morning, and you draw your cortisol levels. Now, no, I did not say go and get your cortisol levels checked. That's the wrong test. That's something in lesson 5. That's how you test for Addison's disease. And this one, I have to give you the pill and see what happens with it. And then check your cortisol level at 8 the next morning and go from there. So, if that test is elevated, because it shouldn't be, right? You should be suppressed. It should be like non-existent because your body thinks you have a steroid in it. So if it's not non-existent, if it's elevated cortisol level, boom. Now we confirm it with a 24-hour urinary free cortisol. So this guy. So this is the first test. This is why it has number 1, right? This is the second test. Good job. Then you also check their plasma ACTH. You can do the same time. So 24-hour urine free cortisol and plasma ACTH. Because that's going to help determine where it's coming from. We'll talk about a lot more about that in lesson 5. Does that make sense? It'll confuse the crap out of you guys. So what's the first test you're going to do if you're suspecting hypercortisolism? Exactly. Dexamethasone suppression test. How do you give it? Exactly. I'll give you a pill. So I know how that particular brand, dexamethasone. I'll give you the pill 11 o'clock at night. It's very specific. Not 11 to 1, not 10 to 9, like at 11 o'clock. And they got to show up to the lab. I have to call the lab the night before. I call the lab and let them know I need to be on alert for this person, this time, like pull the green tag, whatever. They need to know that they need to draw their blood at 8 o'clock the next morning. Because any variance of that will give you a false elevation or suppression of the cortisol test. Cool. Then what do I confirm that test with? I got it, found it's elevated. I feel like I'm on the right track. Then what do you do now? Exactly. 12-hour urine free cortisol and the plasma ACTH. Make sense? Cool. So the other one is nighttime cerebrally cortisol. That's often not found in a lot of your MTFs and also not found it to be reliable source, even some civilian facilities. So I'm only telling that because, noted but disregarded. All I want you to remember is first you start with dexamethasone special test, then you do your 24-hour urine free cortisol if it's elevated, and ACTH. Cool. All right. Make sense? Awesome. All right. So after I confirm that, if I confirm the patient has too much cortisol, we call that hypercortisolism. I don't know maybe where it's coming from. All I did is to confirm they have too much of it, right? So neither one of them is going to tell you exactly where it is, whether I just have too much cortisol. Then you could do imaging. In this case, you're going to do imaging of what structure? Exactly, my brain, exactly. And to make more sense, we get into lesson 5 and talk about what if it's coming from your adrenal glands, what if it's coming from, God forbid, a lung tumor or some other type of adenoma, sarcoidosis. There's other things that cause too much cortisol. So promise we get to that later, but all I'm focusing on is the brain because of the pituitary lecture. So if the MRI is normal, or if there's less than 5 millimeters of irregularity of it, then we do this petrol sinus vein catheterization, which is kind of painful. There's a guy, a later story on top of this, a guy who actually went through this because even endocrinology wasn't sure where the cortisol was coming from. So there's a lot of ambiguity when you're figuring out these tests. There'll be ambiguity on the test, I promise. All right, so the treatment for this, if it is I'm getting way too much ACTH from my brain, that's the problem, is surgery. We talked about it with acromegaly, we talked about gigantism, same thing is surgery in this case. So, curative for 89% of Cushing disease cases. The other thing is interesting because you also have the replacement corticosteroids for a period of time. So basically, if I take out my my adenoma producing way too much ACH, again, the adrenal glands are just dumb. They just do what they're told. So if I took that away, by default, I need some time to take the steroids for a period of time to become more normal. And then you can stop taking them, which is a good thing. And then you do follow-up MRI 3 months. Don't memorize that particular time frame. Just follow-up MRI to making sure you got it all. Radiation therapy can happen as well. And in a very severe disease, like, for example, Danielle, she had to have a bilateral laparoscopic adrenalectomy. So bilateral going out. Yes?
You're with genes here. Obviously, like, you give some steroids to have the signal.
Yeah.
Why is it only 36 months?
Good question. The only thing you're withdrawing is the adenoma. So you're not taking all of the pituitary out. That would suck. I would miss mine. But you're removing the adenoma.
Right.
Yeah.
You're basically going to try to trial them off of this to see if the body comes back over.
Yeah, absolutely, absolutely. And in her case, Danielle's case, so like there's a much cooler story. And there's a website at the end of lesson 5 that gives you some ideas. There's a lot of Cushing disease cases. There's a lot of them. They'll basically, there's a much longer story, but basically she didn't be in a steroid for very long, and her cortisol was still elevating despite the fact she had it removed. So again, that's the reason why she ended up having a bilateral adrenalectomy, and then got pregnant and all that stuff happened after that, but interesting. Questions on that so far? So what's the treatment of choice for if I have Cushing disease? Treatment of choice? Exactly, surgery all day long. Not to remove the pituitary, but get rid of the adenoma. Yeah, exactly. Good, okay. So prognosis is generally pretty strong for Cushing disease. Cushing syndrome gets a more grim prognosis as far as this effect, but they said heart disease, stroke, really cool about that, bacterial infections, suicide. Why would I commit suicide by Cushing disease?
Or stress.
Exactly. The weight gain is profound in some people. And then sometimes you're talking to this person and you don't listen. Talk to you, you don't listen. Talk to you, you don't listen. And you're just like, you're fat, just get over it, just eat less, whatever. And that's very demoralizing. Obesity is a huge thing. We're talking about block 2 about obesity, but that's a big thing. So suicide is a regular apparent thing in both Cushing disease and Cushing syndrome. And it's fairly 15 to 20% chance of recurrence in this case. Kind of blows. So, I wrote when to refer. This is rather current. I didn't invent it. When to refer. Refer meaning punt off to endocrine, but you guys can absolutely do some of the follow-up testing. You can absolutely do the confirmatory testing. You can absolutely do the imaging. You can absolutely do that because I promise you, endocrinology takes fucking ever to get into. Forever. They're very few and far between. People don't like endocrinology. I don't know. But if you get the abnormal dexamethasone suppression test, that result is abnormal, boom, start the referral and do the follow-up testing from there. I've absolutely diagnosed people with Cushing disease and Cushing syndrome, but both, and figured out where the problem was, where it's coming from, etc. And then keyed it up to the endocrinologist and have them go from there. But when you do it, if that test is abnormal, boom, right there. That's the first step to do. All right, questions on Cushing disease? Yes? Great. No, it is very particular at time of day. The reason why, we kind of speak this in that lesson 5, the reason why is cortisol is highest in the morning and lowest at night. Even if you're a night shift worker, it's highest in the morning and lowest at night. So it's very particular. 11 o'clock, lab at 8. Very good question. Good question. Yes?
So they don't make it for whatever reason at that 8 a.m. time frame.
Yeah.
Can you test the next day, or is there a certain amount of time you have to wait?
Great question. So like if you missed the lab, they didn't check it at 8 o'clock, let's say it was 9 o'clock or whatever, what I would do is I give them the dexamethasone suppression test again, give them the pill again at 11, and check it the next day at 8, and call the lab and be like, asshole, why didn't you get it done? So because the thing is you can't check it the next day because the results might be skewed, and what if your test is like a little bit abnormal? Is that abnormal enough to be have that issue? So give it to it again and go from there. Great questions. I love questions. I can't answer, I'll tell you. Alright, cool, take a break. So, like 3 after. So, non-functioning. How on earth would that be diagnosed? Incidental or MRI, exactly. So, often the reason why, go back to various codes talking about space occupying effect. They're going to have space occupying effect even though it's not secreting a hormone, because it's eroding the tissue. So they often present as a macroadenoma because obviously, no kidding, people are not going to present with a microadenoma they're non-functioning. That's diagnosed sometimes in you guys, 10% of y'all. But in non-functioning pituitary-adenoma, we're to present with that. So males present more so than females. Good job, I guess. He said, often found incidentally in imaging, right? I was working up this headache, and this guy was this like horse blinders on. I don't know what his problem was, and then oops, I found this particular adenoma, non-functioning adenoma. Non-functioning pituitary macroadenoma tend to be more aggressive than a functioning macroadenoma. Makes sense, right? Because the space occupying effects, that's the big problem. So I'm having all the negative side effects. We talked about that in the very beginning. So they're getting a headache, no shit, my head hurt too. Visual disturbances, specifically what? Horse blinders, exactly. I have no peripheral vision on both sides. It's not going to happen. It's only on one side. It's always going to be on both sides because I'm impeding my optic chiasm, which is right there next to the pituitary. That's the thing. They also present with hypogonadism. The reason why is one of the failure issues. Sometimes LH is one of the first ones that kind of peter out. So if I were to make LH, I'm not going to make testosterone, and you get hypogonadism. Cranial nerve palsies, go back to the slide. At the very beginning, like kind of old slide, but there's a lot of cranial nerves that are right there, located next to the pituitary, especially like cranial nerve 3. It's a very common one to get affected. But again, just any cranial nerve palsy. And then, God forbid, pituitary apoplexy, which I'm going to lecture you guys about shortly. But if you check the hormonal labs, it's all completely normal. Completely normal. This means a non-functioning pituitary adenoma. Right, so NPA stands for non-functioning pituitary adenoma, that's what that means. If you're causing neurologic symptoms, boom, you do surgery all day long. For example, if I've got the horse blinders on, that's a neurologic problem. Headaches, of course, especially if they're significant, and those are headaches that are often there every single day. It's not being like, oh, I get a headache now, I get another like 10 days. Nope, it's every fucking day. And then ophthalmoplegias, right, so pain in your eyeballs. So that's what you do if it's causing issues, obviously. If you have it asymptomatic, all you do is basically do annual or more often MRIs and hormonal testing, because sometimes maybe it's not functioning now, maybe it's going to be functioning later, so you do hormonal testing. But yeah, at least annual MRIs, you could do every 6 months if it was really big, whatever. So again, even if you have a macroadenoma and it's like fairly big, if it's not causing any issue, you don't have to take it out. Just so you know that. Alright, make sense? Alright, cool. Now we're talking about hypopituitarism. Funny stuff. So deficient in the hormones. So not everything's in the blueprint, so I removed a lot of the stuff and added dwarfism, which is funny to me, whatever. So you may have isolated hormonal deficiency, or you may have a multitude of hormonal deficiencies. Sometimes, believe it or not, an adenoma can get to the size where basically it's, you know what, screw you, I'm going to stop producing this hormone. Before it's producing too much, and now it goes away. So again, you go either direction. But the key you got to worry about is that I've had pan-hypopituitarism. That is the global failure of everything being secreted. Of everything being secreted. That's a huge problem. And the one you need to survive and live your life is you need ACTH, because you have to have cortisol to survive. Of all the things, ACTH, cortisol, you need that to survive.
I have a question.
Yes?
With that being said, does that mean that there's no like supplement for that? Or like, could I take like a man-made version of cortisol and be okay?
Awesome. Yeah, absolutely. We'll talk about that when we talk about pituitary apoplexy. But the man-made cortisol is we do prednisone, that's most commonly used. Dexamethasone is more commonly used. Methylprednisolone we can often use. But that is how we skip way ahead the lesson 5. With Addison's disease, that's how they live. Because if I don't give you cortisol twice a effing day for the rest of your life, you're going to die. Boom, done. So, good call. Make sense?
Yes.
Alright. But what do you got to remember is pan-hypopituitarism, that's a global failure of pituitary. Global failure of pituitary. That's me. I can't. I was in 4-inch heels. You wouldn't know it at the time, but I was in 4-inch heels. But I should take them off. That would be better. But I use like 6, 7, some lame shit. This little, I hate this shit. It looks like awful. Well, like, whatever that's called. Where that is? Yeah, exactly. That was awful. Anyway. He married my bestie, and then they got divorced. But this picture's funny. Probably, yeah, probably. I agree. I don't know. Yeah. Alright. So I'm not a dwarf at this point. You just have to remember that. So dwarfism. So remember, that is a growth hormone deficiency. It often presents in younger kids, so they are recognized pretty easily. So your short scatter greater than 2 standard deviations below normal. So if you look at normal being the 50th percentile, like discover for a second, this is the 50th percentile. So this is, you do this on little kiddos, and you have another one for infants. So 50th for this and 50th for that. That gives you what standard deviation is, so you gotta don't do math. But the key with this is it's proportional. It is proportional. What if I said it was not proportional? What if I said my head was kind of enlarged, my shoulder, arms, and legs? Achondroplasia, exactly. That's completely different. This would be a proportional short stature. So, careful growth dimensions is the way you figure that out. And then you got to exclude the other causes. Have you guys talked about Turner syndrome anywhere? Oh, awesome. Yeah, so we don't talk about that at all ever in endo, but again, so you have to rule out some of these other potential causes for this to happen. Like, why is this person not growing? Is it malnutrition? Stuff like that. That's a big concern for my daughter. I was worried. Thyroid disease, all the other abnormalities that can happen. It is diagnosed with reactive toxin growth hormone. So again, when I check IGF-1 and then fasting and Provocaden, we kind of do the same thing on the flip side. If I don't have enough of this, you don't have to learn any of these at all. Please don't learn them. Insulin, L-DOPA, arginine, GHRH. But again, don't learn those. All you do is you're punting somebody off to either peds endocrinology, where thankfully there's more of those that's adult endocrinology. Peds endo is just pediatricians. And certainly just something to think about if you're thinking somebody has dwarfism. So the treatment, obviously you know what to do for them. You give them growth hormone, but you have to do it before they go through puberty. Why?
Epiphyseal plate closure?
Exactly. Plate closure, all I'm going to do is they give you acromegaly sort of by accident. Exactly. Don't do that. So ankle skin will be bigger, but my body's going to stay the same. So the reason you have to do it before puberty. So you give up injections. So again, this is what it looks like. So often this person's weight is staying pretty stable, normal, kind of boring. It's gone down a little bit. This is the weight chart. But this is the height chart. So he's tracking along the 50th percentile, awesome, normal, and then just fell off there. Fell off to the point where I'm not even on there at all. So actually my height. My height is around the size of a miniature 12-year-old. Good. All right. Any question about dwarfism? Super easy. Growth hormone deficiency. Got it. Often diagnosed younger years. All right. Completely flipping ideas. Sheehan syndrome. You probably talk about this a little bit in women's health, I believe. Maybe. We'll see in senior semester. But Sheehan syndrome is basically postpartum pituitary necrosis. There's very specific things that have to happen with Sheehan syndrome. Obviously, one, you have to be pregnant. What did I say happened yesterday when you're pregnant? Enlarge, exactly, almost doubles in size because we're feeding 2 babies or more. Good job. So what you get is a postpartum pituitary necrosis words. So what happens is after you have a uterine hemorrhage, so she's bleeding all over the place, poor thing. Bleeding all over the place, hopefully saved her life, awesome stuff. What happens is you get hypertension causing vasospasm in the blood vessels of the pituitary. That makes sense? So again, that's what, so you get ischemia, necrosis, everything happens to stroke except for a little baby pituitary, happens up there. So it's interesting because it can present acutely, like immediately after they've already recognized a little mini stroke of the pituitary, or it can present later on in life, which is kind of confusing. But what you have is postpartum amenorrhea and the inability to lactate. So again, I lost my LH, I lost my FSH, lost my progesterone, my estrogen, all that stuff, and that's a problem. So that's the reason why I have these things. Also lost my prolactin levels. Like I said, if acute or delayed, we talked about already. And then some of the other factors, they might have hyponatremia, anemia, and hypoglycemia can happen as a result. Don't memorize those things at all, the hyponatremia, hypoglycemia, anemia, but that's often seen as a picture where it's acute or delayed. And again, the biggest thing we're worried about is sadly this person can also present with acute adrenal insufficiency. So acute adrenal insufficiency, meaning my pituitary, which was making what awesome hormone, among other things, ACTH. So then I lost my adrenal glands. It went to shit because the adrenal glands just doing whatever I told her to do. I don't get any stimulation coming from there. And so I stopped producing cortisol. So they can present with acute adrenal insufficiency, can miss that. So one of the key things, go back to the very beginning, is figure out if this person bled profusely during delivery. So again, if a C-section means she bled all over the place, or a vaginal delivery, blood all over the place, has to be profound bleeding for this to happen. Not everybody's going to get this, but that has to happen. They have to be pregnant for Shan syndrome to happen. Make sense? All right, so this is one pituitary failure disorder, which could actually kill you because adrenal insufficiency will go. All right, now this one, I was wrapping hardcore on this one. So pituitary apoplexy, I linked to this in a little teeny bit yesterday. So this is acute hemorrhage within a pre-existing adenoma. That is a key component to remember. Now, let's say the patient didn't know they had an adenoma. They don't know the Cushing disease. They don't have acromegaly, gigantism, prolactinoma. Maybe they didn't know they had it. And all the signs and symptoms there. Or they knew they had it. They're being treated for that, whatever. Either case, the key with this is it's hemorrhage within a pre-existing adenoma. This is a sudden death of the pituitary. Sudden death. So again, adenoma is too big, bad news. Whether the microadenoma, macroadenoma, does not matter. The sudden death of pituitary. So now, keep in mind, the signs and symptoms of this are kind of, they match your neuro exam on Friday. The first one's there. Sudden severe headache, vomiting, and vision defects, along with some of these other signs and symptoms. These ones are less common, but it's put the most common signs of this. You probably don't care about my story, but I'm telling you, because I can. When I presented the ER, my husband was trailing behind the ambulance. I was completely unconscious. I grabbed the left side of my brain, cursed loudly, vomited right before them, and I did have a visual field defect, which I still have, and then I lost consciousness, right? So they didn't know the story. One of the key things they did for me was treat me for this. They gave me steroids at the bottom, treated the glucocorticoids immediately because that was in the protocols in that ER. Again, I didn't have pituitary apoplexy, not at all. I hadn't even had the CAT scan yet. But you do that for treating the glucocorticoids immediately to save my life. I'm not going to OD on one dose of steroids by any means, not at all. But this is one of the protocols they did in the ER. Does it make sense? Even though I didn't have this condition, but I had all those things, a lot. I had this, altered LOC, hemiplegia, not yet, hypertension for sure, and I didn't have the other two. So I had all those signs and symptoms of that. They didn't know anything about this girl. Boom, give her steroids right off the bat. So, lo and behold, what you're going to do for this patient is give them steroids. It causes acute hypopituitarism, and the one thing you can't live without is ACTH leading to loss of cortisol. That'll kill you. Everything else you can get by with for a little bit of time, but loss of cortisol will fucking kill you. Make sense? Like my weird story. All right. Any questions about pituitary apoplexy? Yes.
On that protocol thing,
Yeah.
can you give those glucocorticoids before you pull out a strip?
Yes. Absolutely, because nothing's gonna kill you. Well, like lots of things can kill you, but bad words. Yeah, so nothing steroid-wise is gonna kill you. Even if it's like a ischemic stroke, hemorrhagic stroke, nothing is killing you. Not at all. I do glucocorticoids before I went to the CAT scan. Before I went there. Most of the ERs will do the same. Okay. All right. Drill in your head loudly and aggressively. But again, keep in mind this is not a typical presenting sign. This patient can have anything. Anything. So again, if in doubt, give them steroids. We'll talk about the dose later. I'll talk about Merlin in lesson 5, but just give them steroids. All right. This one, I meant to go into more depth on this one. I really wanted to because this is a huge thing. So head trauma, which if you've been downrange ever on Earth, head trauma is a very common thing that we're going to see. And a lot of times, like 1 + 1 is not equal to 2. 1 + 1 could be like 45. 1 + 1 + 1 is like 15. Like concussion-wise, people who sustaining blast injuries, EOD guys, they get head injuries a lot. And so this is a really important thing for all you active duty people who are anybody in the military to consider. Because the thing is, these can often present with delayed effects, greatly delayed effects. So the growth hormone and gonadotropins are the most common ones to be suppressed. So growth hormone being suppressed in an adult would probably not be readily apparent. But the gonadotropins, which what I mean by gonadotropins, LH and FSH, and then going downstream, lack of testosterone, or if it's a female, or not estrogen and progesterone. So the lack of those, again, so I'm talking about failure disorders. That is something I've absolutely seen a lot. And I think it's very underdiagnosed in medicine, or at least in my history. So lack of growth hormone IGF-1, right? Like you said, that may not be readily apparent to you because, again, you're not growing anymore. Good job. But the loss of LH and FSH, meaning a loss of testosterone or estrogen progesterone in a female, that's a huge thing. Anytime between the event and if the 36 months post-injury. So if that's something is readily apparent, if you think somebody is having some of like post-concussion syndromes, so basically they're still having, I'm still more irritable or more frustrated. Some of that stuff can happen from the lack of these hormones, and they just think, oh, I'm just really super irritated today. That's bullshit. So consider doing testing in these people. So recommending screening labs include morning cortisol. That is not, by any means, not a dexamethasone suppression test, because I'm talking about it being a failure disorder. Looking like this person presenting like an Addison's patient. So we do that with lesson 5, we'll talk more about that. But the morning cortisol levels, TSH and free T4, awesome, because again, hypothyroidism is a huge cause. LH and FSH, IGF-1, testosterone in males, and estrogen progesterone in females. But again, so it's kind of a slew of labs, but again, the patients will never forget you, I promise. People do not realize, oh, I thought it was just super, forgetful and stuff like that. Some of these, this is probably way underdiagnosed in our community. And I do need another slide in this one, but whatever. All right, any questions about those 3 different causes? Look at Sheehan syndrome, pituitary apoplexy, and head injuries. Those are the 3 big ones they're talking about. Now I've seen a dwarfism, which you talk about dwarfs, so whatever. All right, so if you have, you're looking at the labs. Unless you have panhypopituitarism, which is the global failure of everything, if you, let's say, for example, you have a low TSH, and you also have a low T4 and T3, or I have a low ACTH, and I have a low cortisol. You always have to use 2 labs to understand where it's coming from. But again, the pituitary hormone level and the organ hormone level are both low. Okay, then that's considered a secondary problem. Secondary problem, right? Because where's the primary problem? Exactly, happening with the gland, right? My other hormones doing what it should do. But a secondary problem, meaning your pituitary is not working right, and your dumb gland is doing what it's told and not doing anything appropriately. So again, just an example, it looks like in secondary hypopituitarism, the TSH is low and the T4 is low. Or we can have ACTH is low and cortisol is low. So, yeah. LH and FSH are low, testosterone is low. Makes sense? Okay. Does it make sense so far? Good. Cool. Awesome. Alright. This is just an example of what it looks like. Again, it's not just TSH and T4, this is just an example. Alright, so basically give them what they're missing if you have a deficiency. And again, if they're missing a couple features, give them whatever else they're missing. So growth hormone deficiency, we talked about when you get HGH and injections, sadly it's injection before puberty. If an ACTH deficiency, Addison disease, or pituitary epilepsy, you have to give them a steroid twice a day, every day, for the rest of their effing life, but they'll live. It's a good thing. Yay, good job. Alright, questions before we start clean core, and then you guys are done. Please listen. Any questions? Yes. What questions? Yeah. Great question. So he's asking, like, I don't know if you heard his question. He said, why would you give glucocorticoids instead of concentropin? So concentropin is an interesting thing we use to diagnose, for example, Addison's. Doing that particular drug is not very useful. You do the end result. We're going to use steroids on a daily basis. One, because it's more predictable, plus the concentropin is injectable, and you can take a pill as far as your steroids every day. Good question. No questions? Cool. Click hard again. All right. Sorry, I'm rude to you. Don't be mad at me. 25-year-old G1P1 female complaining of laughter or menstruation and says she hasn't stopped lactating since her child was born 2 years ago. To not breastfeed her child. She also admits to fatigue, decreased appetite, and cold intolerance. Cold too. You remember time with that? Cool. Alright. Vital signs are stable. PSS. Skin is dry. Dress, you notice a bilateral spontaneous milky white discharge. The exam's otherwise within normal limits. So what would you like to do now?
Labs.
Good call. You learn so quickly. So sweet. Yeah. Alright, so labs. So serum HD is negative because, man, the girl be pregnant all day long, right? Serum HD is negative, costs 2 cents. Comprehensive metabolic camel, normal ranges. TSH and T4, normal ranges. Serum prolactin is 225. FSH and LH are both low. So what is your problem list? I did not ask for a diagnosis list, I asked for the problem list. So what's wrong with her? Lactation. What do you call lactation? Galactorrhea, exactly, galactorrhea. What else? Exactly. Amenorrhea. Lack of menstruation also is amenorrhea. Let's see, fatigue, decreased appetite, cold intolerance. That's abbreviation. Okay, good. So we see the elevated prolactin levels included with the abnormalities. So, what should be ordered next? One, you repeat the prolactin level. If you have any doubt about the prolactin level, trust or verify. That's going to hear that a lot. Cool. MRI where? Cool. Exactly. So brain MRI, brain/pituitary MRI. But again, pituitary all it means you give in thin slices. That's the only difference. But it's still a brain MRI. All right. So you have prolactin secreting microadenoma. What do we do to treat her? Medication. What's that? Meds. Which ones? Exactly. Carbagoline or bromocriptine. I don't care which one. Just know the drugs. Don't know the doses. Know the drugs. Carbagoline or bromocriptine. Blah, blah, blah. Get that. All right. Any questions of that prolactinoma? I love you didn't say surgery right off the bat. I'm so proud of you guys. I'd be mad at you. All right. So 30-year-old male complaining of impotency in 10 to 18 months. Payments to fatigue, weakness, and loss of libido. He's about the intermittent headaches and notice a decrease in the peripheral vision in both eyes. So vital signs are stable, no acute distress, height 6'2", weight 260, little huggy. Prominent frontal bossing, wide nose, EOMI, so extraocular motions are intact, good job. Vision acuity, impair peripheral vision bilaterally. I promise to actually do that sometimes. Oral dental malocclusion, that would be more of a history thing. You wouldn't really observe that. He talked about that. A mesostellal enlarged spade-like hands. So spade-like is often something you'll see. They used to be on the pants and pantry. Not so much anymore, but spade-like, it just makes like enlarged hands. Cardiovascular lungs and belly within normal limits. Geotesters are solid, soft without masses. I just all like it because I don't know what happened. Do you think? Wrong? I don't know. Okay, cool. So what's the list of problems? Yes. Yeah, good job. What else? What else? What else?
Vision problems.
Exactly, vision problems. Impaired peripheral vision. What else?
Hypogonadism.
Right, think about it. Alright, aphyseia, small intestinal exam, ready to do exam, headaches, D-shaped peripheral vision, fatigue, weakness. So, what do you do now? What specific lab would you like to do? Random or fasting? You guys listening? Good job. Alright, so random IGF-1 is 524. Boom. Can you confirm, guys, acromegaly? No. Yes, God, I hate you. Don't do it. Okay, good. Now what do you want to do? Fasting IGF-1 followed by, what do we do for the acid tract? Even glucose, 100 grams of glucose. Some texts say 75, but 175 grams of glucose, and then what hormone do I check? Growth hormone, because remember, growth hormone is supposed to suppress. Good job. Proud of you. Yay. And the other labs you're checking also, prolactin levels are also elevated in this guy. Also elevated. And his LH is also be low because prolactin inhibits the LH. So bummer. So growth hormone 1 hour after 100 grams of glucose is 25. Is that abnormal or normal?
Did you shotgun pretty much all your pituitary wall flash?
Yes, absolutely. Well, the thing is, if I'm thinking like, if I think this guy looks like and sounds like this guy has acromegaly, I'm also going to check the prolactin level, and I'm also checking the TSH. The reason why, because a lot of those things can also be skewed. Exactly. So not like I'm checking everything, but a lot of things. Yeah. So again, this is abnormal. Good job. Yeah. So elevated prolactin level and IGF-1 with elevation growth hormone after the glucose. So now what do you want to do for this guy? Exactly. Brain MRI, pituitary MRI. Good job. So again, trust and verify. So do this. Awesome. MRI being contrast. Don't worry the contrast. I don't care about that. Just MRI the brain, pituitary. These are findings. Good job. Hopefully you get to it before the patient does. So again, it's going bilaterally because is this a microadenoma or macroadenoma?
Macro.
Absolutely macro, right? Exactly. So acromegaly secondary to a larger pituitary, that's pretty big, and it's going into the sinuses, poor dude. So what do you want to do to treat this dude? Surgery, absolutely. Surgery is first and foremost. Do you want to do anything on top of the surgery? Exactly, to treat the prolactinoma as well. Remember, that treatment choice for that is medical stuff. So, transvaginal surgery, good job, take out a little adenoma, and cabergoline or bromocriptine, I don't care which one you do, I don't care, just know one of them. And then once stable, you're checking his prolactin levels, make sure it's going down, the IGF and the growth hormone levels annually. Does that make sense? Did I go too quickly? No questions? I'm happy to answer questions.